Okay, I wish to thank the KSM for inviting me and providing me with this opportunity to talk about early detection in as a primary care physician, early detection of cancer. So I'll just briefly take you through the burden of cancer, the importance of early diagnosis, screening, and early detection. So, as you are aware, the incidence of cancer is rising in Sri Lanka. It has almost tripled since 1985. This could be because better reporting of cancer diagnosis, as well as we are diagnosing more cancers rather than actual incidence. But whatever it is, the reported incidence of cancer is rising. And even when you consider age standardized rates, it's still rising. So one important point is when you talk of risk factors for cancer, age is an important risk factor. So you can see that in the 60 to 70 age group, the incidence of cancer is high. So when you're considering like a differential diagnosis, it's important to factor in age. So these are the five commonest cancers among females. Thyroid cancer has risen. It was probably in 2009 it was just in the top 10. Now it has become the second commonest cancer. Cervical cancer was earlier the second commonest cancer. Now it has dropped to fourth place. In males, of course, head and neck, lung, and esophageal cancers together with bowel and prostate cancers are the common. So just when you look at the top cancers among females, you can see that most of them are sort of the cause is unknown, the etiology is unknown. So breast, most of the time, it's just familial and we don't really know what the etiology is. But male cancers are mainly due to smoking and alcohol, head and neck, lung, and esophageal also. So God must be a male because he has given all the idiopathic cancers to females, and all the cancers in males are brought by men themselves. So God must be definitely a male. So in terms of mortality, this is of course data from the cancer control program, so it may not be accurate, but you can see that head and neck and lung is the commonest, and in females, obviously breast because of the incidence. But even though thyroid cancer is the second commonest, lung cancer mortality is higher. So why is it important to diagnose? So if you look at data from the West and our data, so 40% of all breast cancers in the West are stage 1. In our setting, it's just 23. About only 5% of cancers in the UK are diagnosed with metastasis, but in our setting, nearly 13% are diagnosed with systemic metastasis, and these cancers are incurable. So 13% of all breast cancers in Sri Lanka, at the diagnosis itself, it's incurable. Lung cancer, you can see it's anyway a cancer where metastasis is high even in the UK, but you can see that in our setting, we hardly diagnose any lung cancer in the early stages. Whereas in the UK, about 25% are diagnosed in stages 1 and 2. Esophageal cancer, same situation. Head and neck cancer, which is the commonest cancer among males, also most of our cancers are stage 3 and 4. Again, it's not comparable with Western data. So we don't have data in our setting, but even in the UK, about 20%, 1/4 of all cancers are diagnosed in the emergency department, and about 1/4 of the patients who are diagnosed in the emergency departments will have a mortality within that year. So diagnostic delays are a problem even in the West, but in our setting, it's much worse. So why should we diagnose cancer early? One thing is the outcomes are better. If you diagnose it at an earlier stage, the outcome is better. The second reason is that treatment can be less intensive. For example, you instead of a mastectomy, you can do a wide local excision, a breast conservation surgery. And also it's cost effective. The cost of treatment will be less if you diagnose cancer early. So this is data from our setting. So if it's stage 1 and 2, you can see survival is almost more than 80%, even in our setting. When you diagnose it at stage 3, drops to about 60%, and of course stage 4, breast cancer is incurable. And this is the difference. I don't have to tell you, the quality of life is obviously better with breast conservation surgery than with mastectomy. So there can be many reasons for late diagnosis. Some cancers like pancreatic cancer, even ovarian cancer, present later. Symptoms present only after the cancer has spread. There could be patient delays. Again, breast cancer we see quite commonly. They seek Ayurvedic treatment. They wait. Some of them detect the lump and keep the lump. And also there could be physician factors. Some patients, particularly lung cancer, we found that they do present to a clinician, but it takes about 2 to 3 months sometimes to reach a diagnosis. Various investigations are being done, you know, and they go from clinician to clinician. So this is an aspect where we can do something about. And of course, the systemic factors, like for example, access to bronchoscopy, access to endoscopy, access to imaging. Sometimes, even if you detect, even if you see a patient and you request a CT scan, the date is given in 6 weeks, 8 weeks sometimes. So there are systemic factors. So it's multifactorial, but we can at least reduce the physician factors. So various strategies you can think about. Screening is one strategy. Health education, and of course early detection and referral by primary care providers. And this is what I'm going to talk about mainly today. And also streamlining diagnostic pathways. So first thing is screening. So screening is identifying disease before the onset of symptoms. So treatment is initiated early. So these patients are by definition asymptomatic. So before, ideally we should detect it before invasion or metastasis has occurred. Sometimes it's difficult, and we can initiate treatment, less morbid treatment. So the community physicians will say this is a secondary prevention strategy. So slight difference between screening and early detection. Screening is when you diagnose it before onset of symptoms. Early detection is in symptomatic cases, but basically the same principles apply. So cancer screening began with the pap smear, 1941, and since then it has evolved to a lot of other cancers as well. So not every cancer is suitable for screening. You have to look at the epidemiology. It should be a widely prevalent cancer. You should look at the natural history. There should be a long natural history, sort of a long pre-symptomatic phase. And there should be a simple and effective screening test, and it should be cost effective uh, for the health system. So now there is no point diagnosing sort of hepatoma. Of course, the hepatoma incidence is rising, so we are now thinking about screening for hepatoma. But the disease should be widely prevalent. For pancreatic cancer, for example, well, the incidence isn't high, so there is, when you're initiating a screening program, that is not an ideal cancer. And there should be a benefit of diagnosing early. So thyroid cancer, for example, doesn't sort of progress very much. So it is not a very lethal cancer. So there is no point sort of screening for thyroid cancer. In fact, the data suggests that screening for thyroid cancer causes more harm. So whereas breast cancer, there is a clear benefit of diagnosing it early. And ideally, you need a detectable preclinical phase. So cervical cancer is a cancer where this is ideally placed. You have a long asymptomatic phase where you can detect the cancer. And of course, as I mentioned before, prognosis should vary substantially with the stage. So the screening tests should be highly sensitive, specific, and it should be reliable and easy to administer and cost effective, and you need a confirmatory test too if the screening test is positive. So what are the problems with cancer? Now, in spite of its sort of theoretical advantages, a lot of cancers trials have not proven a benefit in terms of mortality because a large number of asymptomatic patients have to be screened, and you're sort of doing this in asymptomatic patients. These patients have no other symptom, and so we don't really know whether there is a benefit. The magnitude of the benefit of screening is a bit uncertain in some cancers. And of course, when you screen for a cancer, you are diagnosing the indolent ones. The cancers which are long-standing, slowly progressive cancers tend to get diagnosed rather than the aggressive ones, which probably need to be diagnosed early. So anyway, let's go through some of the cancers where screening is useful. So breast cancer, this was of course a trial done in the 70s. The health insurance plan study showed a reduction in mortality. So you detect breast cancer early, ideally before the invasive phase. There is a prognosis is better, and you diagnose it before metastasis has set in, and treatment is also less morbid. So what are the screening tests? You can do mammography, self breast examination, clinical breast examination, and of course magnetic MR mammogram. Again, not for everybody. So mammography is the only modality where there's been sort of a mortality reduction has been shown. So it's low dose X-rays to image the breast. You look at a mass, architectural distortion, and calcifications. So the sensitivity increases with age because the breast density reduces with age. The glandular structures of the breast undergo regression. So when you're after about 40 years, it becomes cost effective, ideally 50 to 70 years. It is reasonably specific, but you need to do it at least twice biannually, that is every 2 years. Otherwise, you will be missing out the aggressive cancers. But there are a lot of problems. Now, these are patients where you have to detect it in patients without a mass because they are asymptomatic. So the confirmatory test, if you detect a lump, then you need a mammographic guided biopsy or an ultrasound guided biopsy. So that is not easy. The pathology is a lot complicated. In the very early cases, sometimes it's difficult for the pathologist also to say whether there is cancer or not. They need a lot of other additional tests. And in the age groups that we really want to pick them, like the younger ages, it's not effective because the breasts are dense. So in younger patients, the mammography is not very effective. So when you put all these together, the cost effectiveness has to be factored in, which is why in Sri Lanka we don't have a population mammographic screening program yet, because the system cannot support such a strategy. So MR mammogram, again, it's very costly, but if there are patients with high risk factors like genetic syndromes, strong family history, then you can offer it to them. Again, it's very sort of specific, but there is a high false positive rate. But if the MR mammogram is normal, then you can be pretty sure that you don't have a sinister cancer, but it detects a lot of other indolent lesions as well. So self-breast examination is what is being promoted by the ministry, but of course there is no evidence that it improves mortality, because for a patient to detect a lump, it needs to be of significant size. And in Sri Lanka, the problem that we face is patients detect a lump and then still keep it. So because of that, promoting self-breast examination actually sort of increases breast awareness or breast cancer awareness, and it sort of creates a pathway for patients to seek treatment. So that is why the ministry is promoting this. It's very cheap, so there's hardly any cost involved. So it is what is being promoted by the ministry. Clinical breast examination, so performed by a healthcare worker, ideally a doctor. Now, this is also offered through the well-woman clinic, but a public health midwife is the one who does the examination. So we see that even in undergraduate examinations, postgraduate examinations, we have candidates who miss breast lumps, significant size breast lumps are not detected. So you can see if a midwife is examining, they also miss a lot of significant breast lumps. So this is not a very effective strategy as a screening method, but again, still the ministry is promoting it, but there is no evidence that it improves outcomes. When done together with mammogram, then it has a benefit because it can detect cancers not missed by a mammogram. So what about individuals at high risk of developing breast cancer? If you have a BRCA mutation, particularly BRCA1, you have a 75% risk of developing breast cancer. Again, it's not 100%. So these patients, some of them decline prophylactic mastectomies. You can put them on a screening strategy also. If you have one first degree relative uh, with associated BRCA associated cancer, even if you do not have the mutation, you are still at high risk. Two or more. So one first degree relative alone without a genetic mutation, it's not really high risk as such. That can be just a sporadic cancer. But if you have two first degree relatives, then you are at high risk. So screening for these patients should commence 10 years before the age of onset of the youngest relative, but not before 25 years. So if it's less than 40 years, we would have to put them on MR mammographic screening, which is again very challenging in our setting. So what are the guidelines? So UK says 50 to 70 years every 3 years. United States Preventive Task Force, which is the public health body, says it's 50 to 75 every 2 years. The American Cancer Society, that's more sort of clinicians and sort of public driven society, so they recommend the annual mammogram. In our guidelines, it says 50 to 70 years, every 2 to 3 years, when the facilities are available. That's what the ministry recommends. So facilities are not available at the moment. So we are left with self-breast examination. But if you have relations between 50 and 70, it's better to, of course, offer the mammogram every 2 years. Then moving on to cervical cancer. Again, as mentioned before, it's the ideal cancer for screening. There is a long preclinical phase. The diagnostic test is simple and its treatment is also quite easy when it's diagnosed early. So this is, it's caused by HPV, and you have a phase where the patient is infected with HPV, then they go on to develop in situ cancer and then invasive cancer. So you can detect HPV infection, you can detect the pre-invasive phase, and you can, of course, detect the invasive cancer. So what we practice is the cervical cyclone, the pap smear. That is offered through the well-woman clinic. Every female above 35 years is offered this test. There is a pilot study on HPV DNA detection that's being conducted. We are hoping that would be introduced soon. And then also you can, there is a newer method of with acetic acid or glucosidine. Again, a pilot study was done. It's very cheap. The pap smear costs us less than 300 rupees per test. So it's as a screening test, it's very cost effective, unlike mammograms, which cost more. So DNA, if you detect HPV DNA, you can sort of identify and initiate treatment earlier before the pre-invasive phase sets in. But again, there are problems with that because the infection may resolve. Not everybody goes on to develop a cancer. But in other countries, they have moved to detecting HPV DNA rather than just cervical cytology. Now, visual inspection with acetic acid, again, pilot study. It's not for younger patients. It's suitable, but not offered in us. So currently, the recommendation is every sexually active female above 35 years should undergo cervical cytology. If the screening is negative, it should be repeated every 5 years. Now, what happens? So if it's normal, you re-screen at 5 years. Uh, so if it is so then you categorize it as in situ lesions, low risk and high risk. If it is low risk, then you repeat the test in 6 months. Otherwise, you have to go down to a colposcopy. If there's invasive cancer, you need a urgent gynecological referral. Moving on to colorectal cancer. Again, it's a sort of a cancer that meets the criteria. You can see males and females, it's within the top 5. There is a long, sort of reasonably long preclinical phase. There are effective screening and diagnostic tests, and of course, the outcome is very much variable. Very much dependent on stage. So, stage 1, you have a almost more than 90% survival. Whereas if it spreads to the lymph nodes, stage 3, survival drops to about 60%. And metastatic cancers are incurable. So lots of tests again, fecal cord blood, sigmoidoscopy, colonoscopy, and virtual colonoscopy. But there aren't, each modality has been tested separately against standard of care, but no comparison between the modalities. So we don't know which is the best method of screening. But fecal cord blood is a relatively sort of cheap and non-invasive test. So, of course, there is no primary prevention with fecal cord blood. I'll talk about that when I'm discussing colonoscopy. The modern tests are not affected by diet, so it's immunochemical test. And if the fecal cord blood is positive, then you need to refer the patient for colonoscopy. Flexible sigmoidoscopy is sort of a compromise between colonoscopy and fecal cord blood. Because the bowel preparation is minimal, you can detect the left-sided cancers. But and if there are adenomatous polyps, you can remove them so that they don't progress into a cancer. So there is primary prevention as well. Colonoscopy requires, full bowel preparation, and we are now seeing a shift from the left side of the colon. Most cancers are now, so there is an anatomic shift. We are diagnosing more and more right-sided cancers, so which will be missed by a sigmoidoscopy. And again, if you detect polyps, you can remove them and stop them progressing into cancer. So there was this study was published actually 2 weeks ago, 1 week ago actually, October 9th. So it's the Nordic trial where they did a randomized control trial of single screening colonoscopy. All the patients, standard risk, no risk, additional risk factors. Patients were offered a single colonoscopy, and the other control group was offered standard usual care. There was no difference in the intention to treat group, but only 42% of patients who were invited to undergo a colonoscopy actually underwent the procedure. So when they were told of the complications and all that, more than half declined to undergo. So this trial, again, lot of controversies because mortality was reduced in patients who underwent the colonoscopy, but in the whole intention to treat population, there was no difference in mortality. So lot of it's hotly debated now. So you can see on the left is the intention to treat group. That means it includes patients who were invited. Only half of them underwent the colonoscopy. You can see there is no difference in mortality. The curves are virtually on top of each other. But on the right is the patients who actually underwent a colonoscopy. Now these patients, the mortality is reduced. You can see the screening group mortality is almost half of that of the usual care. So, but as a trial, the trial is negative. But when you look at go into details, uh, it is positive. So it depends on whom you want to speak to. The gastroenterologist would like to promote this trial and say you have to undergo a screening colonoscopy, whereas the community physicians may say it's a negative trial with no evidence to support it. Anyway, so CT colonoscopy is an alternative, sort of another compromise. Again, it can detect lesions, but no primary prevention component is missing. So, colorectal cancer is a bit, the risk stratification is a bit complicated. So, basically, you need to look at three factors: inflammatory bowel disease, past history of polyps, and family history. If all these three are negative, then your risk is average. And for average risk patients, the American Cancer Society recommends a fecal occult blood test annually. UK, it's every 2 years. Americans say 45 to 75 years. UK is a bit more conservative, so they are saying 60 to 75. And you can see the American Cancer Society recommends, as an alternative, they recommend a colonoscopy every 10 years. But UK does not recommend that because it's a public health system and they're looking at cost. So whatever it is, if you've got a patient who is interested in sort of cancer screening, you can offer a fecal occult blood test if between sort of 50 to 70 years as a compromise. And so intermediate risk, you need to start the screening a bit earlier, but you can do the same population screening. If it's high risk, you would have to do colonoscopies every 5 years. So I think these patients, of course, you would better refer to a specialist center. If you've got any of the mutations, then it becomes more complicated. So familial adenomatous polyposis, you can actually do a sigmoidoscopy because it mainly first occurs in the sort of left side of the colon. But if it's HNPCC, you need to do a full colonoscopy. Again, best refer to a gastroenterologist to manage. Lung cancer, again, it is one of the leading causes of mortality. And as I mentioned before, outcomes depend on stage. Stage 1, it's 70 to 80%. Stage 3, 4 drops to less than 10%. So the only test that they tried was in smokers, low dose chest CT and HRCT low dose. The National Lung Cancer Screening Trial in the US showed a reduction in mortality. And it is recommended by the Americans for smokers above 50 years with a 20 pack year history. Prostate cancer screening, so in our setting it is not cost effective, so maybe I don't know whether even in the private sector whether this is worthwhile. But if you've got a smoker and you're sort of, the patient is very enthusiastic, maybe you can consider offering. Prostate cancer, lots of controversies. There is no difference in mortality proven, and the confirmatory test is very invasive. You need a trust biopsy, and most of the cancers are indolent. So, and PSA has lots of problems in itself. So, it is not a cancer which is suitable for screening. Again, prostate cancer, we tend to diagnose the low indolent cancers more than the aggressive ones. So the UK recommendation is that if a patient wants to undergo PSA test, you should counsel the patient on all of these factors: the uncertain benefit, toxicity of confirmatory test, and toxicity of treatment. Right. Moving on to early detection of symptomatic cases. Now, there are physician delays because now the medical education is telling us that a clinician uses two methods to reach a diagnosis. One is when you're sort of very junior, you will be using the hypothetical deductive approach. You'll be looking at causes of hemoptysis or causes of rectal bleeding, and you try to exclude them one by one. As you gain experience, you rely on pattern recognition, and the more experienced clinicians will say this is Graves' disease, this is acromegaly, um, and so on. So the problem with cancer is that for an individual symptom, the likelihood of cancer is low. If you got a patient with rectal bleeding, the probability of cancer, that being a cancer, is still, even rectal bleeding is less than 10%. So if you rely on pattern recognition, you will miss these out. So to detect cancer in the primary care setting, we need to go back to the hypothetical deductive approach and sort of actively exclude a malignancy. Yeah, so this is what I was talking about. So we know these patterns like the classical flank pain, hematuria, flank mass, but that's only seen in 10% of all renal cell cancer. So painless progressive obstructive jaundice, carcinoma of the pancreas, until proven otherwise, but most of these are at that stage are inoperable and metastatic. So if you rely on patterns, you are going to miss a lot of malignancies. So these are the positive predictive. Rectal bleeding just 8%, altered bowel habits 6%. Hemoptysis, even in a smoker, only 1/5 of them will have a cancer. Postmenopausal bleeding, only 5% will have a cancer. Even breast lump, 90% are benign. So individual symptoms, the likelihood of cancer is lower, but you need to actively exclude them. So just to run through quickly some cases. So this was a 54-year-old smoker diagnosed with COPD on inhalers. So a patient with COPD but had a 3-week history of worsening cough. Examination, there was clubbing, right? And there were bilateral crackles and bronchi. So he went to the GP. So in our patients, they go to one GP. If it doesn't get better, they go to another GP. And that is what happened. Then we led to the medical casualty, again treated with antibiotics. Chest imaging was not done, which was passed off as an exacerbation of COPD. But then 3 weeks later presented with chest pain, and then imaging was finally done, and you can see a lung mass. So, but in this patient, looking back, this patient had clubbing, so that should have alerted some sort of a sinister cause. And it was a new onset cough. It wasn't, the patient is complaining of a cough that was different to the usual exacerbation of COPD. But in defense of the primary care physician, they would say that if you have to do imaging of all of these patients to come up with exacerbation of COPD, it's not, they would be overburdened. So these are the challenges in early diagnosis. But clubbing is certainly a clue that should have warranted further imaging. Yeah. So again, if you relied on pattern recognition, you would have missed this case. So the NICE guidance say these, so new onset cough, chest pain, shortness of breath, fatigue, all of these should warrant chest imaging. Again, challenging in our setting, but we should keep that in mind. The possibility of lung cancer in a smoker who presents to you. So the second case was a patient with abdominal pain, no altered bowels, no bleeding per rectum, and again presented to the surgical casualty. They did a X-ray KUB. There was no sort of, they excluded a renal stone, but there was anemia. So the patient was, however, that was missed, and the patient was discharged. When the patient presented 3 weeks later, he had epigastric pain that was attributed to the NSAIDs, and again a repeat ultrasound was now requested because the patient was complaining. Then comes to the medical casualty. Again, anemia is now worsening. Then the endoscopy is done and a cecal mass is detected. So again, altered bowel habits, flank pain, the symptom, the likelihood of cancer is a bit low, still should be investigated, but anemia in a 60-year-old should have warranted a search for more sinister causes. So the NICE guidelines say any patient with iron deficiency anemia should be screened for bowel cancer if above 50 years. So, and these symptoms, these are something totally. you have to think about. Remember what I said. So cancer is common among the elderly population. So as you above 50 years, any patient with altered bowel habits, you should think of uh, bowel cancer. So this patient, another important case. This is a patient with sore throat, a smoker with sore throat, 3-week history of sore throat, no difficulty in swallowing. So uh, the primary care physician examined and there was nothing found, and so discharged with antibiotics. Again, there was no improvement in symptoms. A slight sort of reflux-like symptoms were complained. A cough was also sort of mild cough. So again, antibiotics prescribed, bronchodilator was added, omeprazole added, but only when the lymphadenopathy presented was a search for cancer done, and that revealed a epiglottic tumor. So persistent sore throat. This is not even in the UK early detection guidelines. They don't mention sore throat, but in our setting we see the ENT surgeons will agree with me. Persistent sore throat in a smoker or an ex-smoker is a sinister symptom. If it sore throat lasting more than 2 weeks, you should do some form of fiber optic endoscopy to exclude a malignancy. And the fourth case, again, vague abdominal discomfort, urinary frequency, and dyspepsia in a 56-year-old female. Examination is entirely normal. UFR is checked, it is normal and reassured. Then backache is worsening, so X-rays are done and reassured. As sort of a myeloma screening is done, that is also normal, so the patient is reassured. And altered bowel habits was done, and she is now referred to a colonoscopy and an ultrasound scan. Again, that is a routine ultrasound scan, so the appointment is given in 4 weeks. And the ultrasound scan detects a tube ovarian mass. So again, an ovarian cancer that took some time to be diagnosed. Of course, in defense of the primary care physicians, again, all ovarian cancers, the symptoms are vague. But in a sort of female above 50 years, a high index of suspicion is needed. So, any patient above 50 years feeling bloated, even urinary frequency can be a symptom of ovarian cancer. Altered bowel motions can be a symptom of ovarian cancer also. So, they should be, apart from bowel cancer, they should be screened for ovarian cancer also. So, just to run through the each sort of tumor site. So, any breast lump, I don't have to tell you, needs to be investigated, particularly if the age is over 30 years. The risk of cancer is high. Colorectal cancer, we discussed this, so I'll skip this bit. So fecal tucker blood, I just want to mention this. If there is any history of rectal bleeding, there is no point doing a fecal tucker blood test. You have to refer for a colonoscopy. And if there is anemia also, still, even with the above 60 years, you have to do a colonoscopy. So it is fecal tucker blood is a good screening test, mainly in asymptomatic patients. Okay. So ovarian cancer again discussed. CA125 sort of should be done if you're looking for ovarian cancer. So that these patients need to be referred to a gynecologist. So if it's more than 35, you need to sort of do imaging. I'll just skip that bit. So endometrial cancer, postmenopausal bleeding is as you know, endometrial cancer until or unless proven otherwise, even though only about 5% of patients will have a endometrial cancer, because it should not be missed. And any smoker or ex-smoker, hoarseness of voice, throat pain, neck mass, and in the oral cavity, any oral ulcer, submucous fibrosis should be referred for to a specialist center to exclude a cancer. Lung cancer, this is a cancer where again we are sort of diagnosing it very late. So hemoptysis, persistent chest infection, a new onset cough, shortness of breath, and clubbing. You should think of a lung malignancy. So upper GI cancers, of course, I think dysphagia is preferred, but the cancer presents late. Again, dyspepsia, new onset dyspepsia above 50 years. Don't pass it off as as GORD, and don't prescribe PPIs and discharge the patient. You should refer for a endoscopy. And of course, hepatobiliary cancers, again detected late, but a high index of suspicion is needed. Prostate cancer screening is controversial. If a patient is highly enthusiastic, then you can offer a DRE and a PSA in patients who are more than 55 years. If the patient has got symptoms, lower urinary tract symptoms, then in that group, of course, you should do a PSA after you have treated for an infection. So again, bladder cancer is another cancer which is sort of diagnosed late, particularly in patients who have microscopic hematuria. So painless hematuria, always think of a bladder cancer, and even sometimes the history of pain can be vague. So sort of any patient with hematuria, particularly above 45 years, that age group, you need to refer to a urologist. And so testicular mass, these patients, of course, these cancers are rare, but any testicular mass should be referred. So for completeness sake, any penile ulcer should also be referred. So unexplained weight loss, think of GI cancers. In females, think of ovarian cancer also. Another important aspect is DVT. So about 5% of cancers are diagnosed, present with DVT. So if you get a patient with unexplained DVT, you have to exclude a underlying malignancy. So the pathways are sort of, this is the UK sort of guidelines, and you can see lots of symptoms, lots of linked to lots of cancers, so it's complex. But if you break it down, it's not very difficult. Bottom line is sort of above 50 years with sinister symptoms that don't resolve, last for 2 weeks, think of a cancer. So diagnosis delayed is treatment delayed, and remember, treatment delayed is treatment denied, because curable cancer can become incurable. There is the national guidelines on early detection is there. You can download it here, and also the NICE guidelines on early detection also. Thank you very much.